Chapter 16, Caring for Patients with Hematologic Disorders. Chapter Objectives. Clinical Objectives. In the human body, healthy red blood cells carry oxygen to the tissue. A balance is maintained between production of new red blood cells and the disposal of worn out red blood cells. Anemia actually occurs when something interferes with the balance or the maturing of the cells. Anemia is a state in which there is insufficient numbers of functioning red blood cells or a lack of hemoglobin to meet the demands for oxygen. Anemia is not a disease. It is a symptom of a disease or a pathologic process. Anemia can either be chronic or it can be acute. Things that one might notice is if a patient had gastric bypass surgery or a gastrectomy, there is a risk of pernicious anemia because there will be a diminished availability of the intrinsic factor. So as a nurse, we know that we need to watch for pernicious anemia in these patients. Patients who take medications over a long period of time that may suppress gastric acid secretion, proton pump inhibitors would be an example. They need to be watched for signs of pernicious anemia. Supplementing with vitamin B12 injections or sublingual may help to avoid this issue. Nutritional anemia is where there's an inadequate intake of proteins, folic acid, and iron. There's anemia that results from bone marrow suppression caused by toxic substances. And then there is megaloblastic or pernicious anemia, where there is malabsorption of nutrients that are necessary, like vitamin B12. There is end-stage renal disease where erythropoietin is not produced by the kidney, so red blood cell functioning is not stimulated. And there's hemolytic anemia, which can be due to genetic defects that affect the cell structure, and this would cause the cells to disintegrate rapidly. Thalassemia and sickle cell disease are inherited diseases, where others are acquired when erythrocytes are exposed to a poisonous agent. Iron deficiency anemia occurs when total body iron is insufficient and the production of red blood cells or erythropoiesis is diminished. The lack of iron will impede the formation of hemoglobin. Megaloblastic anemia or pernicious anemia is an autoimmune disorder. The intrinsic factor is missing from gastric juices, and vitamin B12 cannot be absorbed without this factor. Vitamin B12 acts like a coenzyme in conjunction with folate metabolism, and it is needed for iron and proteins to manufacture the red blood cells. The result of missing the intrinsic factor is that red blood cell production is diminished, and those red blood cells that are produced are probably abnormal in their structure and their function. To treat this condition, vitamin B12 will be given, and any folic acid deficiency would be corrected. Hemolytic anemia is associated with excessive destruction of red blood cells. However, it is quite rare. When red blood cells are not normal, they break up easily and are destroyed by the body more quickly than normal red blood cells. The red blood cell destruction causes the anemia. Oxygen transport depends on the number as well as the condition of all the red blood cells. as well as the amount of hemoglobin that each cell contains. Signs and symptoms of various anemias from causes due to other factors besides rapid bleeding will depend on whether the anemia is categorized as mild, moderate, or severe. Tachypnea and tachycardia may develop with severe anemia due to the decreased ability of the blood to transport oxygen to the vital tissues. To assist in diagnosing for anemia, a peripheral smear, which is a microscopic look at red blood cells on a slide, will provide information about the cell's abnormalities. They'll look at the size, the shape, and the color of the erythrocytes that are in the patient's blood. The complete blood cell count, or CBC, with a differential cell count, these are used to diagnose the presence of anemia. So the CBC looks at red cells, the differential cell count looks at the white blood cells. Maintaining the quantity of hemoglobin determines whether the cells will have sufficient amounts of hemoglobin to carry the oxygen necessary to sustain the tissues in the body. A hemoglobin that is less than 12 in women and 13 in men will define anemia. When looking at anemia, the treatment will depend on correcting the underlying problem and then building up replacement blood cells. Anemia that is caused by inadequate iron, folic acid, or protein can be managed with oral iron supplements, vitamins, and diet adjustment. If the anemia is severe enough, blood transfusions or intravenous iron may be administered. Megaloblastic anemia is treated through regular administration of injectable vitamin B12. It can also be given orally, sublingually, or intranasally. Because of the deficiency of the intrinsic factor, this prevents the absorption of vitamin B12 from food. It also will inhibit the gastric absorption of the medication. So that makes the sublingual route results in more of the drug being absorbed rapidly. There must be an adequate folic acid in the diet or through a supplement. Aplastic anemia is considered a rare disorder. The toxic effects of some substances may be responsible for aplastic anemia, like benzene, insecticides, some medications, gold compounds that treat rheumatoid arthritis, and things used in chemotherapy. As a nurse, we need to promote public education about dangerous toxic agents. People need to understand they should read as well as follow the label instructions on cleaning products, insecticides, and chemical compounds. Aplastic anemia can cause an emergency situation, and the treatment must eliminate the identifiable underlying cause. The impairment or failure of the bone marrow function leads to the loss of stem cells. This is the cause of aplastic anemia. With aplastic anemia, the bone marrow has decreased cells and an increase in fatty tissue. In addition to signs and symptoms of iron deficient anemia, there's also ecchymosis, petechiae, and hemorrhage that is related to a low platelet count. These signs and symptoms may also be observed. Infection with aplastic anemia is common, but may not cause an inflammatory response because of the low leukocyte count. With aplastic anemia, there is frequently bleeding in the patient's mouth. Sickle cell disease is a genetic disorder where the gene is inherited from both parents. Sickle cell disease is characterized by a gene mutation that causes a production of an abnormal hemoglobin S rather than hemoglobin A. Sickle cell is found in 8 to 10% of African Americans, but sickle cell also will affect Hispanics, South Asians, and Caucasians from Southern Europe, as well as individuals from Middle Eastern countries. Sickle cell trait is considered as heterozygous, meaning that the person has an inherited gene for the trait from one parent only. People with the heterozygous trait for sickle cell are carriers. They cannot transmit the gene to their children even though the individual does not have any signs of the disease. The defective hemoglobin S polymerizes when hypoxia is present. This causes the cells to form the sickle shape, block blood vessels. They can break apart and form thrombi that can cause organ damage. Sickle cells are destroyed by the body very quickly, causing anemia. The lifespan of the sickle cell is roughly 10 days compared to that of 120 days for the hemoglobin A. Sickle cell disease will indicate the presence of the hemoglobin S. As long as the cells are not causing a blockage in the circulation, no symptoms will be present. However, when the cells do clump, the blood flow is impaired, and the signs and symptoms are those that indicate a lack of oxygen and blood flow. Things like pallor, lethargy, as well as pain. Periodic episodes of pain are called sickle cell crisis, and this indicates a lack of blood flow in the small vessels. The problems due to the interrupted normal blood flow will affect many organs. There will be painful swelling of the hands and feet related to the bone infarction from the sickle cells, known as hand and foot syndrome. After the sickle cell crisis, routine signs of typical anemia occur because the abnormally shaped cells are fragile, they break easily, and then are destroyed. The red blood cell and the hemoglobin counts can drop very rapidly during a sickle cell crisis. Treatment for sickle cell is focused on preventing the sickle cell crisis and managing symptoms if the crisis occurs. Patients need to be taking folic acid regularly and eating a diet with adequate protein to help build red blood cells. Infection needs to be prevented, and the patient should receive all the recommended immunizations against influenza, hepatitis, pneumonia, tetanus, and other diseases. Adequate intake of fluid is important daily to keep the blood as fluid as possible. Alcohol and recreational drugs are to be avoided because they can cause complications. If the individual becomes ill, they need to call their physician. The medication hydroxyurea has been found to reduce the frequency of the sickle cell episodes. Patients taking this medication have shown a decrease in their number of hospitalizations, painful episodes, acute chest syndrome, and the mortality rate. If a sickle cell crisis occurs, the patient may be treated at home with bed rest, adequate fluids, and analgesic. Pain control is what is vital during a sickle cell crisis. Narcotic analgesia with morphine is administered on a continuous basis, usually by a PCA pump. If the patient's hemoglobin drops considerably or their condition deteriorates, they are then going to be hospitalized, provided oxygen and IV fluids, and transfused with packed red cells. An attempt will be made to mobilize the sickled cells and to prevent damage to the major organs. If infection occurs, it will be treated with appropriate antibiotics. Nursing care for these individuals looks at relieving the symptoms from the complications of sickle cell and minimizing any organ damage. Nursing individuals teach their patients to avoid high altitudes, vigorous exercise, as well as iced liquids. We do, however, advise our patients to drink an adequate amount of fluids every day, which would be 2,000 to 4,000 milliliters of fluids. Refrain from smoking, and if they get an infection, to seek treatment. Adequate rest is also important for these patients because they will often experience fatigue. With polycythemia vera, the blood will become thick from the increased number of cells. The blood vessels will become distended and the blood flow will be sluggish. Due to the sluggishness of the flow of blood, there is a tendency to make blood clots. Blood pressure will be elevated and the heart will hypertrophy. Bleeding is common in areas of distended blood vessels. Signs and symptoms of polycythemia vera would include a reddish face with deep red purple lips, fatigue, weakness, dizziness, headache, splenomegaly or an enlarged spleen, and a very congested liver. Treatment is aimed at reducing the number of blood cells and then preventing any complications. Some of the methods would be by phlebotomy or anti-neoplastic agents and radiation therapy. Leukemia has three major effects. It increases the numbers of the abnormal and immature leukocytes, the accumulation of these leukocytes within the bone marrow, and the eventual infiltration of the malignant cells throughout lymph nodes, the spleen, and other bodily organs. Leukemia, when it is translated, means white blood. Since the disease is a cancer of the bone marrow, which produces white blood cells, that's why it's named. There are various types of leukemia. Some are more likely in a child, and some are found basically in adults. Specific leukemia type, age, and the physical condition of the individual determine the best treatment options. Malignant production of white blood cells is the actual cause of the disease. The DNA will become damaged and abnormal cells production will result. An acute leukemia is one where there is a large number of immature cells called blasts. These cells don't mature and they stay in the bone marrow. This impairs the production of healthy cells. In chronic leukemia, the abnormal cells build at a slow rate, allowing the production of some normal cells. Leukemias are also classified depending on the origin of the abnormal cells. Myeloid leukemia will arise from bone marrow. However, lymphoid leukemia has its origin in the lymphatic system. Patients that have chronic leukemias are often asymptomatic, and the disease is detected with a routine physical and a CBC. Some signs and symptoms of leukemias may include fever, headache, bone pain, pallor, weakness, fatigue, malaise, infections, swollen lymph nodes, enlarged spleen, may see weight loss, and easy bleeding or thrombosis. Diagnosis is made using a history and physical, the physical exam, the CBC with differential, and then bone marrow studies to rule out other such disorders. Leukemia treatment, no matter what the leukemia, always tries to decrease the growth of any malignant cells We want to maintain the normal level of red cells, hemoglobin, and platelets. As nurses, we help manage the symptoms and meet the needs of each patient. And then we will assist patients to explore potential curative treatments. Infections from bacteria, a virus, and fungus are the most common cause of death in people that have leukemias. Infection is a threat either because of the abnormal function of the bone marrow that is characteristic of the disease, or it could be due to the suppression of bone marrow function as a result of any treatment therapy. As a nurse, we help prevent infection, and we are vigilant at our assessment for early signs and symptoms. Abnormal bleeding may be a result of the low platelet count, and this is the second most common as well as dangerous complication of leukemias. As nurses, we observe the patient, we're aware of the patient's current platelets, and we prevent trauma to body tissues and vessels that could occur due to a low platelet count. If the nurse initiates neutropenic precautions on a patient who had chemotherapy, which action would be considered appropriate? Use clean technique for wound care and invasive procedures. Use protective isolation as necessary. Allow visitors. Maintain integrity of skin and mucosa. Provide analgesics as needed. The correct answers are 2 and 4. Thrombocytopenia occurs when the platelet count drops to less than 150,000. This can be a life-threatening condition. There are various causes. It could be bone marrow suppression from chemotherapy or radiation. It could be an autoimmune disease. It could be a bacterial or viral infections. It could be disseminated intravascular coagulation or an overfunctioning of the spleen. Some drugs like non-steroidal anti-inflammatories and thiazides can also decrease the platelets. An increased use of heparin preparations for DVTs has led to greater occurrences of heparin-induced thrombocytopenia. Heparin will trigger antibodies that prompt the platelet activation, resulting in forming of clots, which depletes the platelets. When platelet counts are low, the primary problem is clotting. Immune thrombocytic purpura is the most common acquired thrombocytopenia. It is an autoimmune disease in which there's an abnormal destruction of circulating platelets. In the immune thrombocytopenic purpura, platelets are covered with antibodies. In the spleen, these platelets are now recognized as foreign and they're destroyed by macrophages. The disorder commonly occurs in women between 20 to 40 years old, and the chronic form has a gradual onset with transient remissions. Many patients that have thrombocytopenia are asymptomatic, but there are some signs and symptoms of thrombocytopenia. It can include purpura, which are purple spots and patches, as well as small areas of multiple petechiae in the skin and mucous membranes, or it could be large bruised areas caused by hemorrhage, and these are known as ecchymosis. Bleeding can occur in any part of the body, and hemorrhage is the major concern. Some patients will recover spontaneously. Otherwise, corticosteroids are administered to reduce the destruction of platelets, and IV immunoglobulin, or for some patients, IV RHO immunoglobulin will be administered. A splenectomy usually results in lifelong remission. A cautionary note: as a nurse, we know that these patients bleed easily. So anytime we do any actions, start an IV, we need to make sure that site pressure is held for 10 minutes because it'll take a while for the patient to clot, and we don't want the blood to keep oozing out of the patient. Multiple myeloma is a disease in which neoplastic plasma cells infiltrate into the bone marrow and destroy the bone. Men are affected twice as often as women, and the disease occurs in African Americans twice as often as Caucasians. The disease usually occurs after 40 years of age, and the average age of diagnosis is about 65. In multiple myeloma, abnormal plasma cells multiply out of control in the bone marrow. The accumulation of these abnormal cells will disrupt the normal red blood cell, white blood cell, and platelet production. The disruption of normal cell production may lead to anemia, impaired immune response, making the individual susceptible to infection, and bleeding tendencies. The tumors will disrupt the normal bone marrow function and weaken the bone, which will then predispose the patient to frequent fractures. Multiple myeloma is diagnosed by a combination of X-rays, bone marrow biopsies, as well as blood and urine tests. The appearance of light chains from abnormal immune globulins in the urine, known as Bence-Jones proteins, is a diagnostic sign of multiple myeloma. Because the bone destruction during multiple myeloma releases calcium, a hypercalcemia may lead to kidney stone formation and renal impairment. The CBC will show anemia, leukopenia, and thrombocytopenia. Bone marrow studies will show a large number of immature plasma cells. There are many treatment methods for multiple myeloma. Chemotherapy and hematopoietic cell transplant are often used to help combat multiple myeloma. Pain control is a primary concern. We know that hypercalcemia and osteoporosis will develop oftentimes, and patients need to be monitored and treated for these specific complications. Measures must also be taken to help prevent any pathologic fractures. Chemotherapy are individualized to the patient based on the results of testing. Agents like Velcade or Revlimid, as well as dexamethasone, are first-line therapy for multiple myeloma. Additional therapies will include radiation to target areas of pain, erythropoietin, plasmapheresis, and surgical interventions. In multiple myeloma, the nurse helps provide supportive care for the complications and the treatment. We encourage an adequate hydration with an intake of 3 to 5 liters of fluid, which would be 3,000 to 5,000 liters of fluid a day, to help minimize any problems from hypercalcemia. This is a priority for nursing. The average fluid intake is 2,000 to 4,000 milliliters. Pain assessment and management are crucial to the quality of life for the patient. Acetaminophen and some NSAIDs are used along with narcotic analgesics. Care should be taken when moving this patient due to the potential for fractures. Psychosocial care is essential because the disease has remissions and exacerbations and eventually is fatal. The patient and family must be taught about signs and symptoms of hypercalcemia and be instructed to report these signs and symptoms immediately. Measures to prevent falls need to be instituted. Mental status is monitored closely, and measures to protect the patient are instituted if confusion does arise. Hemophilia is an inherited X-linked disorder where there is a deficiency of a specific clotting factor. Classic hemophilia or hemophilia A with a factor VIII deficiency will affect 20.6 out of 5,000 males in the United States. Hemophilia B, also known as Christmas disease, causes a deficiency of factor IX. Christmas disease affects 1 in 30,000 males. Because of the deficiency within the clotting system, both types of hemophilia are characterized by delayed blood coagulation that produces a prolonged period of bleeding after an injury or surgery. The types of hemophilia almost always occur in males and are genetically transmitted through the mother. Although the mother does not have this disease, she and all of her female offspring are carriers for classic hemophilia. Female carriers of the X-linked recessive condition are usually asymptomatic, but under certain conditions, they may exhibit mild hemophilia. Acquired hemophilia can affect both genders, but the disease is quite rare. Hemophilia can develop as a result of formation of an antibody to clotting factors and blood transfusions in patients with collagen vascular disease or after a drug reaction. Idiopathic occurrence may be seen in people greater than age of 50 years old. Von Willebrand disease is a genetic disorder in which the von Willebrand clotting factor is absent or defective. This protein binds factor VIII, helping to form clots. When it is absent or it dysfunctions, platelets do not clump appropriately. This will affect men and women equally. The most obvious symptom of hemophilia is bleeding. The hallmark sign of hemophilia is bleeding into joints. This will cause a loss of mobility and unequal extremity length. Bleeding will also occur internally with leakage of blood into the intestinal or peritoneal cavity and into deeper body tissues. Hemarthrosis, known as bleeding into the joints, produces swelling, pain, warmth, and limitation of movement similar to that is experienced by patients that have rheumatoid arthritis. The diagnosis for hemophilia is through history, physical exam, CBC, a coag panel, and tests for different clotting factors. In the most common types of hemophilia, transfusing the missing blood factor will prevent bleeding. Recombinant forms of factor VIII and factor IX are available and administered intravenously at various dosages as well as intervals based on clinical data. Safe analgesics for hemophilia patients are acetaminophen, oxycodone, codeine, and tramadol. Prophylactic factor treatment may be administered before a dental procedure or in advance of other invasive diagnostic tests, as well as unavoidable surgery. In addition to administering the needed clotting factors, other interventions will include elevating the injured body part, applying cold packs, controlling the patient's pain, observing for additional bleeding, and providing psychological support for the patient and the family. We as nurses should also encourage genetic counseling for family members. Disseminated intravascular coagulation, known as DIC, is a complicated disorder that usually occurs in conjunction with tissue destruction. It is not a disease, but it is a complication of a significant clinical condition. It usually accompanies serious problems like severe trauma, gram-negative sepsis, shock, respiratory distress, malignancy, a transfusion reaction, an amniotic embolus, as well as abruptio placentae, which is when the placenta separates from the uterine wall. With excessive clotting, this depletes the body's clotting factors. The bleeding will then follow, which could lead to hypotension or shock. DIC can present as a life-threatening emergency, or it can be a chronic process. Vascular volume is maintained with fluid replacement and vasopressor medications. Mechanical ventilation may be needed to support oxygenation as well as ventilation. Packed red blood cells are given to support circulation and perfusion. Fresh frozen plasma may be given to replace clotting factors if significant bleeding is present, and platelets may be transfused if the platelet count is below 10,000. To minimize the risks of circulatory overload, infection, a transfusion reaction, or other issues related to blood administration, blood is routinely transfused only when there has been a large volume of loss, when the patient has a deficiency of a blood component, or when there must be a total blood exchange in a newborn. Autologous blood transfusion, which is giving of one's own blood, is used when the patient's own blood can be collected and reinfused. The blood is collected either during or after surgery, or blood is donated by the patient prior to surgery for later use. The patient must have a signed consent form to receive a blood transfusion. If the patient is unable to sign and the condition is life-threatening and there is no family member available, the healthcare provider can make that decision to transfuse the patient. The determination whether the patient has an IV site established and noting the size of the catheter that is in place. If a transfusion is necessary, a 18-gauge catheter should be used. We need to ensure the patency of the infusion site before obtaining blood products from the blood bank. The only solution that is to be used with blood products is 0.9% normal saline. No other fluids or medications are to be given with blood or blood products. The administration set for blood is specific, and it is primed with normal saline and set up before going to the blood bank to retrieve the blood. After retrieving the blood from the blood bank, it must be infused within 4 hours. If the blood is not going to be infused, it can be returned to the blood bank if it has been out of the refrigerator for no more than 30 minutes. The actual word reaction means a sensitivity to the blood itself or a sensitivity to the preservatives or other substances that have been added to the blood product. Reaction to red blood cells are the result of an incompatibility between blood types. Antigens on the surfaces of the red blood cells can bring a reaction when exposed to blood that is not the same type, making it incompatible. The antigen-antibody reaction will cause the cells to clump together and obstruct the flow of blood through capillaries. A major blood reaction routinely results from giving the wrong blood to the patient. A mild reaction is usually treated with antibiotics in the donor blood and not the red blood cells themselves. As long as there are no signs of any adverse reaction, the patient is assessed and vital signs are taken every 30 to 60 minutes until the transfusion is complete, depending upon the institutional policy. Infusion of ABO incompatible blood or components containing greater than 10 milliliters of red blood cells. Antibodies in the recipient's plasma attach to the antigens on the transfused red blood cells, causing the red blood cell destruction. As nurses, we need to meticulously verify and document patient identification from the sample collection to the component for infusion. Most ABO compatibility reactions are the result of giving the wrong blood to the wrong patient. When managing hematologic disorders, we need to ensure that patients have oxygen therapy, they have an adequate intake of iron and B12. If the hematologic disorder is severe enough, a splenectomy may be accomplished through surgery.